So the data in M0 CRPC is fairly new. We have evidence from the SPARTAN trial and the PROSPER trial showing that Apalutamide or Enzalutamide treat in men with PSA progression who have no obvious signs of metastases on conventional imaging but are progressing biochemically, that there is a delay in the time to progression if they receive improved metastasis-free survival if they receive enzalutamide or apalutamide. So there's no doubt whatsoever that metastasis-free survival is an important endpoint. However, there's a lot of controversy regarding, does the entity M0 CRPC really exist? So if we actually get those patients and do more modern imaging, for example, PSMA PET-based imaging or whole body MRI, are these patients actually metastatic? That's one issue. Secondly, especially in the UK, we tend to be quite evidence-based. We try not to overtreat our patients. And I personally believe there's a real danger of overtreating patients if all comers with metastatic or with M0 CRPC are treated with these agents. In my view, it'll lead to a major lead time bias. In other words, patients starting treatment long before they need to. These patients can live quite comfortably with just being on ADT, and adding apalutamide or enzalutamide, while it may delay metastatic progression, we have no evidence whatsoever that it influences survival. So it may be that patients are just being exposed to these drugs for a longer period of time. And that's important because these drugs have consequences, both financial for the healthcare system that's paying for them, but very importantly for the patient as well. These drugs, especially enzalutamide, causes a lot of fatigue and cognitive impairment. Apalutamide similarly has effects on bone mineral density. So it may be that what we're actually doing is putting these men at greater risk of fractures and bone health, and also potentially decreasing overall physical capacity. So my worry is that if we overtreat these patients, we could end up, we could delay the time to metastases, but have no influence on their survival and end up in fact having a worse overall general condition. And a lot of us in the UK are very keen to try and identify these patients if there are small volume metastases and treat them with radiation, stereotactic radiation or radiation for oligometastatic disease. We feel that this potentially could prolong the time to needing one of the more advanced agents, which is good for the patient, it's good for the payers. And overall, we need evidence to support this. There are a number of clinical trials ongoing, the CORE trial being the most obvious example in the UK, where oligometastatic disease is being treated with radiation, the idea being delaying the time before you start one of the new hormonal agents.